Hello, everyone, and welcome to another episode of Ty and Sky's Health Pub. It is with a heavy heart that we present this episode. Our guest, Tom Nehring, passed away shortly after production of this episode. Tom was a man with great vision for the state of North Dakota. Tom dedicated his life to improving emergency medical services and was a true trailblazer for improving rural healthcare delivery. We share Tom's vision of systematic care improvements and hope to continue his mission moving forward. From all of us at Ty and Sky's Health Pub, we thank you, Tom. Hello, everybody. Welcome to another episode of Ty and Sky's Health Pub. I'm Sky, and I'm joined here today with, of course, Ty, our other co-host, and we are here today with Tom. Hello, Tom.
Hello.
We are coming live from the North Dakota Department of Health, and we will be talking to Tom here, who actually is the Director of Emergency Medical Systems here at the North Dakota Department of Health, and we will be talking to him about specifically systems of care. So first, I guess starting off, Tom, first, welcome to the show. Thank you very much for joining us today.
Yes. Thank you for inviting me.
Oh, not a problem at all. Not a problem. First, we wanted to ask, for generally for people, when we first say, systems of care, it's like, what's that? So can you kind of go into a little bit to us and just for our viewers as well? What exactly do you mean by systems of care, and why is this something that people should know?
Well, so first, what I'm going to focus on today are systems of care as it relates to emergency medicine. Okay. And I think the best way to describe a system of care is basically you have to take into account all of the elements that make up a system of care. So when we think of someone who typically has an injury or has an emergency, whatever the situation may occur, you may think of one element of the system. You may think of an ambulance service as an example, or you may think of a hospital where someone is going to perform surgery as an example. The problem is that the whole system has to work together in synergy to be able to basically alter the outcomes in a very positive fashion, and that starts from the onset. So when I talk about onset as an example in trauma, it's usually some type of traumatic event, a car accident or something like that. If we talk about cardiac, we're talking about maybe a myocardial infarction, and with a sudden onset. Or if we talk about stroke, we're talking about an onset of stroke. So what has to first happen as the first element of a system of care is that has to be recognized. Either recognized by the individual who is suffering that, or someone who is with that individual, or somebody who observes the car accident, and then is able to communicate to basically start putting into motion the different resources that are necessary within that system. So they're an integral part of the system as well. So the next step then is communications through a dispatch, public safety answering point, those types of things. They make the determination what the appropriate resources are that need to get to the side of that individual. Then you typically have first responders. Doesn't necessarily mean an ambulance service. It might be a trained first responder who's trained just in such, in life-saving kinds of techniques, maybe followed then by a quick response unit, law enforcement, fire, followed by a transporting ambulance. Then, of course, with the rural nature of the state of North Dakota, we have a number of critical access hospitals out there, but critical access hospitals may not be able to provide for definitive care. So all of the elements we've talked about to this point in time probably cannot provide for definitive care. And what is definitive care? Definitive care is something that turns around the situation that has occurred. So as an example, if somebody has a ruptured spleen, due to a traumatic event, the bystander, the dispatcher, the first responder, law enforcement, fire, ambulance service, the small critical access hospital without a surgeon are not going to be able to render definitive care because that's a surgical emergency. Okay. So that individual then has to get to a larger hospital where there's a surgeon present who's able to then render that definitive care and stop that bleeding. Okay. But the system is reliant on all steps and all elements to be able to move that patient appropriately through all of those elements so that you have the best outcome of the patient.
Okay. So we're kind of looking at, kind of like you mentioned, we're looking at all these pieces, whether it be the ambulance, whether it be the bystanders in the area that the time an event may occur for somebody, all the way up through the surgeon at the hospital. Systems of care is really looking at how all these pieces connect.
Correct.
Perfect. Going along with that, why is it necessary to look at it from that perspective?
Well, I think there's one, I think, overwhelming reason, and that is the system is only as strong as the weakest link.
Okay.
So if you have failure at any element along the continuum of care, that basically, and basically time, when I talk about time critical conditions, it's normally a window of time where that person needs to receive definitive care. So we can take a number of time critical conditions. You also hear them as time sensitive conditions. Sudden cardiac arrest. Okay? Sudden cardiac arrest, you get your best statistics with regards to an individual where you can reverse that by having somebody at the side of the patient doing CPR, has an automatic defibrillator, and then has other parts of that system responding, moving that patient throughout those systems to the point where definitive care can occur. STEMI. STEMI is an ST elevation myocardial infarction, okay? And basically what we typically talk about is we've got a window of about 90 minutes to get that individual from the onset to definitive care. Now, definitive care occurs within a cath lab, okay, a cardiac cath lab. There's only 6 cath labs in the state of North Dakota. So if you're out in Crosby, North Dakota, and you have a STEMI, it behooves that system to get the patient to, and in this particular case, Trinity Hospital, within that 90-minute time frame, so that they basically can remove that clot in the coronary arteries, and that makes it effective. We can say the same thing about strokes. Strokes typically we're looking at a 3-hour time frame, so you have to move that patient, depending upon where they are, to where definitive care is. And trauma is one where you've typically heard in the past the golden hour. Golden hour is, difficult to accomplish in some places in North Dakota just because of the travel time. But that's what I mean by getting them to definitive care. So that has to be recognized almost from the beginning so that all of those pieces can be put into motion, so that basically what you've done is you've helped the outcome of that individual by making sure that all the steps of the system are working appropriately.
Okay. So being more mindful of, I guess, as a layperson, right, say in a time-critical event such as a cardiac arrest or sudden cardiac arrest, say if I'm just a layperson, so being knowledgeable of systems of care would actually be helpful in terms of encouraging me to learn certain procedures, like maybe say I learned CPR, or knowing knowing these type of things would actually help improve that flow through the system of care, or properly, say, giving the right address to dispatch, for example, wherever the issue might be at. So is this kind of like the line of thinking for a normal person kind of approaching in terms of if they're thinking of a system of care, kind of how they should be molding their thoughts around and how they can improve the speed of which, or the efficiency of which, someone goes through a system of care?
Well, I think you picked a really good example. And the reason why is because typically as a bystander, you can affect survival statistics in a very significant manner with regards to sudden cardiac arrest. So if you take a look at the areas of the United States that have been very successful with regards to resuscitation of sudden cardiac arrest individuals, it's usually somebody who recognizes that a cardiac arrest exists right away, is able to do bystander CPR, is typically followed very quickly by an automatic defibrillator, or an ambulance service that may be there with a manual defibrillator, defibrillate that patient, and then move that patient through the rest of the system of care. But let me tell you how significant those statistics are. If you can accomplish all of those steps, I think the average survivability from sudden cardiac arrest in the United States is somewhere around 5%. Not a very high percentage. Mm-mm. You take a look at King County, which is out in Seattle, and basically they've put that system into place. I think that they have trained about half the population in that area, which is a large population, in doing bystander CPR. Basically, they have kind of a pit crew approach where they have people who respond as quickly as possible. Their survival statistics have increased from the 5% to 62%. Wow. So when you talk about can you as public affect what goes on, you can affect it greatly through such things as doing bystander CPR, through such things as making sure that this is reported immediately, that all the appropriate resources are being headed, to that particular situation, whatever it may be.
So, yeah, what we're finding is that kind of the population itself or the public itself is a very important part of this system, a very key part of this system in saving the life of that person that may be having the heart attack or the cardiac event.
And, in the past, what we've tended to do in healthcare is we've tended to build silos. And I've spent a lot of time in hospitals. And so the most important aspect of emergency care is the emergency department. Or you spend a lot of time in ambulance services. The most important, resource is the ambulance service. Well, we're past what is important. We're at the point where the system needs to work together, and that's what is important. It isn't the single elements within the system itself.
Okay, so you're talking about it's very important for this cohesion across the whole system.
Synergy.
Yeah. Perfect. What are you doing kind of at the state level to increase the synergy amongst those departments and maybe we'll say build a bridge between those silos?
Well, I think it all starts first with education. Okay? And I think that we have a responsibility, and let me tell you that there are many good people across the state of North Dakota that I think feel the same way about system development. So it isn't just, the North Dakota Department of Health that is taking this on, but there's many people who work, either in the field, in the hospitals, whatever the case may be. And so what we have as a responsibility, I think, is to educate. We have to educate the public. We have to educate them that, first of all, recognition that something has happened. Then we have to educate them how to seek help. We have to educate, for instance, dispatchers. And we have to educate them how to give instructions. So if you have somebody who doesn't know how to do CPR, they can give basically instructions over the phone, have the individual doing that. They also need to then, call the appropriate resources. So let's say law enforcement might be the closest appropriate resource and who has an automatic defibrillator, as an example, or a fire. And maybe it takes a little longer for the ambulance service to get there, but you get all of those head in that direction. Then it's important that the ambulance service recognize, what their role in this is. If the patient has already been basically successfully resuscitated, they need to be supportive while they take that individual off to a cardiac center, as an example. So, all along, what's important for us is to educate all of the elements of the system. And you do that through, CPR instruction. You do that through public announcements. You do that through a number of different things. And most of the EMS people have already caught on to this. The other part that I should talk about is that not all of the hospitals in the state of North Dakota are able to render definitive care, as I've already said. So we use the example of the surgeon. Well, we can also use the example of a cath lab. So there's 6 cath labs within the state of North Dakota. We also now have a program within our stroke system that basically where we have what's called acute stroke-ready hospitals. Most of the critical access hospitals are stroke-ready hospitals, which means that they can offer definitive care. When you have a stroke that is what we call an ischemic stroke, one that is caused by a clot in one of the vessels of the brain, then basically they can give clot-busting drugs at the critical access hospitals and then move that patient. So you fit within that time window. If you do have a hospital that is not acute stroke ready, then the ambulance services recognize that and they will bypass that hospital in favor of a hospital that is an acute stroke ready hospital. And then up the ladder we have primary stroke centers in the larger hospitals, et cetera. But you can see what we're doing is building blocks, the appropriate blocks for people to be able to take advantage of moving that individual patient through the system as quickly as possible.
Okay, and kind of a term that I've heard you talk about a few times in our discussion so far this morning, critical access hospital. Could I have you define that for us?
Sure. So in the state of North Dakota, we have 44 hospitals, okay? We have basically 6 tertiary care hospitals. Those are typically thought of as the 6 largest hospitals.
Okay.
In the 4 major communities, Minot, Grand Forks, Fargo, and Bismarck.
Okay.
Then what we have is we have the remaining 38 hospitals in the state of North Dakota are typically critical access hospitals. Those are the smaller hospitals located out in the local communities, and they're called critical access hospitals because that's a designation that basically they get through CMS, which doesn't make any difference one way or the other, but Centers for Medicaid, Medicare, where they have a designation as a critical access hospital. They're critical. They don't necessarily have a whole lot of inpatients, and they don't have all of the services that you're going to find within a tertiary care facility.
Okay.
But they would be considered the local hospital.
Okay.
And they don't have the capabilities necessarily that all of the larger hospitals have. Certainly they can take care of some patients and do their job very well, but some patients need to move on. So if you have a critical access hospital without a surgeon and you have a surgical patient, they need to move to basically a tertiary care facility. And in our case, if it's a traumatic event, basically we also have a trauma system within the state of North Dakota where we as the health department designate trauma centers across the state of North Dakota at different levels. We also designate acute stroke-ready hospitals and primary stroke centers. We do not have the criteria yet to designate cardiac hospitals, but we do know that definitive care as far as cardiac is concerned needs to take place within a cardiac cath lab, so that means you need to move that patient to one of the tertiary hospitals.
Okay.
And so kind of going with this idea of moving people through the system, especially in the event of a cardiac arrest. In this case, I guess from the initial layperson's perspective, what is really, because we hear a lot of the times in the media about different expectations of, say, bystanders giving aid and not providing aid at times, or someone might see an event take place and they don't necessarily provide any aid because they're afraid of being sued, or we've heard stories before of people have malpractice, like any sort of major issue happening for rendering aid when probably it would have been better for them not to have done anything. Or what in your stance? What is the case here in North Dakota? Is it more that people should just try to help if they're not medically trained, or is it just for these instances should they try to get? Can they actually help, I guess would be the better question.
Well, and so I think that obviously they can be of great help. I think it's a rare situation where any harm would come to the patient because of an untrained individual trying to render aid. You can only think of some circumstances of moving patients when it shouldn't be moved and so on and so forth. But, let's take a look across the country. You oftentimes see it in news clips around the United States of a car that's burning, okay? And you have the local bystanders go and they tear the door off and they move the people. So that would be somebody who would perish had it not been for them. The best case scenario that we can talk about, the most appropriate one, goes back to sudden cardiac arrest. Without that bystander CPR, and I'm just going to tell you this, that if you do not start CPR in somebody who is in a sudden cardiac arrest, if you do not start CPR until 10 minutes into the arrest, that individual has a 0% chance of survival.
Wow.
So how many times can you get a first responder there within 10 minutes? Now, we'd like to think that that would happen frequently, but oftentimes the person who is there is a bystander. And you don't even have to know CPR, although I will, certainly I believe that some training in CPR is necessary. They've made it much better than what it used to be. It's hands-only CPR now as opposed to mouth-to-mouth and CPR. And that's where you get somebody starting CPR that can really make the difference. As I said earlier, you get somebody who immediately starts CPR, they can be defibrillated within a few minutes, they come back into a viable cardiac rhythm, and you've got a successful resuscitation. You start after 10 minutes, when somebody arrives on the scene, you no longer have a viable patient.
Okay. And when you say defibrillated, you mean like the shocking?
Yes.
That shocking of the...
And of course, it used to be that at one point, and I can remember when all of this occurred, okay, only because of my advanced age, that defibrillation only occurred within hospitals. Mm-hmm. And then we moved to defibrillation occurring within advanced life support ambulance services. And now basically it's commonplace for automatic external defibrillators to be placed in strategic areas throughout communities that basically can be run by pretty much anyone. So you have somebody who's trained in CPR and has access to an external defibrillator, and they can use that defibrillator. You've got a very good chance of basically saving that individual, resuscitating them successfully before any other trained people arrive.
Yeah, and I guess kind of along the lines of that, so that brings up a really interesting piece about technology and maybe how it affects systems of care. Do you know of any other examples of the way technology has kind of changed the way the whole system works, similar to that?
Technology always, you need new bells and new whistles within healthcare all of the time. And, if you take a look at some of the technology now as compared to not that long ago, technology plays a huge role and is going to play even a bigger role in the future. But just let me give you one example, okay? So I can use a personal example for this. So technology, it used to be not that many years ago, and I'm going to talk about the early 80s, where basically even physicians in the smaller communities weren't able to determine, because of the lack of technology, what kind of heart attack occurred, okay? So now what we have is we now have EMS agencies, even basic life support across the state of North Dakota, are able to do 12 lead EKGs and transmit those to a cardiac center so that the 12 lead EKG can be read, and that diagnosis as to what kind of heart attack that is prior to that patient ever even reaching there. Now, when I said that, I'll use this particular example, my father sat in a very small hospital in North Dakota without a diagnosis as to what had caused his heart attack. Ultimately, he ended up having so much myocardial damage, heart damage, that he ended up dying. Now, if they would have been able to transmit that, or they would have been able to determine what the 12-lead EKG was, and this is the definitive care that could have been rendered, I think it would have been a little different story than what it is now. So technology, and that's just one area. Technology is exploding across all parts of medicine and also all parts of emergency medicine.
But it can be hard to keep up.
Yes. Well, and that's one of the problems that you have. Everything has become expensive. So we have real issues within the state of North Dakota. Our EMS agencies are facing a crisis, and it's mostly based on workforce. For many, many years, what we have done in the state of North Dakota is we have relied on the volunteer within the state of North Dakota. And the volunteers, for the most part, we have about 124 ambulance services in North Dakota. Basically, about 110 of those are volunteer-operated ambulance services. So as that volunteer pool basically becomes diluted or starts to disappear, we have real workforce issues within the state of North Dakota. Then you couple that with the need for technology and how much technology costs. Basically it costs more money to run ambulance services these days than ever before, even though you have volunteer labor. So, it can basically drive an ambulance out of business.
And kind of going back to these ambulances, you were speaking earlier before about advanced ambulance services or advanced life support services. Could you mind, I guess, giving us a little bit of a distinction between the different types of ambulance service? I guess between I've heard of a basic life support service versus advanced life support. Would you mind kind of giving a distinction between those for us?
Sure. So a basic life support ambulance service has to have a minimum crew in the state of North Dakota as an EMT and a CPR, emergency vehicle operations trained driver. Okay, that's the minimum crew. And an EMT only can offer basic life support. So they cannot start IVs, they cannot give medications, they cannot do those types of things. Then we have the second level, which is advanced life support. That's typically, right now, the minimum makeup of an ALS crew, advanced life support crew in North Dakota, is a paramedic and an EMT. So that paramedic can do such things as intubate patients, give medications, cardiac medications, and many other medications as well too. Start IVs, do many of those advanced life support things. And so that's really the difference between the two. And we find that, advanced life support, probably the most appropriate area for advanced life support is out in the rural areas because of the longer transport times. The problem is affording them. And, once you start putting those amount of hours into your education, then typically you're looking for a career position as opposed to being a volunteer, although we certainly do have volunteer paramedics within the state of North Dakota. But essentially that's the difference. One can give a level of basic life support. The other ambulance service can give advanced life support.
And so in the rural communities where we're facing this idea that where kind of the pool of volunteers is diminishing, what kind of things are being done, I guess, to kind of help alleviate that? Are there any sort of solutions in the works or any sort of workarounds or ideas that have come from kind of that problem taking root?
Well, we're really faced with a crisis at this point in time. So a lot of the people who have volunteered for ambulance services in the past are now getting to the age where they probably cannot volunteer as much anymore. There's always basically recruitment to try to fulfill those positions that are being emptied. That's not always successful, but you find that there are many different kinds of activities employed by volunteer ambulance services to try to get more individuals. It might be somebody at a lesser level. It could be a driver who has CPR as an example, and so they recruit them. It could be an EMT, and so there's always a lot of educational efforts to try to train individuals at the level of EMT, and of course we also have quite a number of paramedic programs in the state of North Dakota, but it really is up to the individual ambulance service as far as how they're going to fill their roster, and it's becoming more difficult on an annual basis to do so.
So what are some ways that are some techniques that you can use to try and alleviate that loss?
Well, so I think one of the things that we have to start looking at within the state of North Dakota is more of a tiered response system. So right now, in the past, what we've done is I think that we have probably relied too heavily on ambulance services. Okay, so ambulance services, at least out in the field, are the most expensive resource that you have, that can respond to an emergency. I think we need to start looking more at tiered response systems. So I think we need to look at individuals who have minimal amounts of training, who are able to be at the side of the individual as quickly as possible, who then call in the other resources. I think we need to have greater utilization of law enforcement, greater utilization in working together with fire, and then basically, ambulance services, quick response units would basically be something where you don't have all of the staffing requirements, but they basically can be on the scene. So it's a tiered response where you're not just waiting for an ambulance to show up on the scene.
And so it's also in a way about efficiency of the system itself, right? So in a way that it's about not having to utilize resources or activate resources that you wouldn't normally have to activate yet, depending. So say if you just sent everyone in a local community, like they have one advanced life support service, they send out everyone, the police, the fire, everyone comes out to one event, but the one event didn't actually need all those pieces.
Yeah, it's appropriate response, and hopefully what you're going to do is you're going to get enough information from the individual who witnesses this, so that the dispatcher can make a determination what resources are appropriate to be sent out. Again, you make a good point, because if you overutilize resources, then those resources may not be available for something else. Not necessarily even at that time, but overutilization over a long period of time causes stress, those types of things. We also haven't talked about, rapid transportation in between, facilities as an example. So, we do have a number of helicopter systems and fixed-wing air systems within the state. And I think we have to probably do a better job of utilization of those to be able to move patients, especially large geographical distances, to, as an example, if we're going to do a patient transport to a tertiary care facility. One of the things that we've done in the state of North Dakota is over the years we've regionalized healthcare. We regionalized emergency care. And so far, when we talk about system development, that's one of the things that is a result of that, is because what we now have is an emphasis on movement of the individual to definitive care, okay? So definitive care usually, the things that we're talking about, exists in one of the 4 large cities within the state of North Dakota. So if you basically have a patient in Crosby, North Dakota, which is basically 130 miles from Minot, and you have a ground ambulance that first goes out to the scene, gets that patient, those types of things, then typically if they cannot be taken care of within the hospital in Crosby, North Dakota, and they have to move that patient to Minot, and you do it by ground ambulance, basically you've got a couple of more hours on the road.
Yeah, it's going to take a lot of time.
So maybe the appropriate thing is if you can make the determination at the scene that maybe a more rapid form of transportation, such as a helicopter or a fixed wing, might be more appropriate, that those basically could be dispatched and be waiting for, by the time you get that patient out of the scene, maybe to the Crosby Hospital, whatever the case may be. So again, that's another part of the system that many times maybe is underutilized and in some cases overutilized. So it's the appropriate utilization of resources and the most efficient use of resources.
So do you see it kind of as as a balancing act then, in a way, say with regards to how if someone, because we spoke before about the tiered system response, so say if we're trying to put that out where we recognize how much resources need to be utilized at an earlier time, do we expect people that are very low trained, like you said, they would have less training, these individuals in the tiered response initially? Is it just a balancing of who at what point recognizes at what point those things need to be utilized? Because if it's earlier, if usually, like, a lot of research has suggested that the earlier that advanced support gets involved, that the better the health outcome could be for the patient. So is it more of just determining when's the best time to determine when to use those things?
Well, I think, one of the things that needs to happen in a tiered response system is, I think, that the people that can be at the side of the patient the quickest need to go. But I think you need to follow that up basically with the medically trained individuals as well too, to make a determination whether this person needs to continue on within the continuum of healthcare. So yeah, I think it's someone's going to have to make that medical determination as well too, and maybe the first responder can't do that. Maybe law enforcement can't. Maybe fire can't. Maybe the ambulance service may be able to, or maybe they need further diagnostic testing within the critical access hospital, but at some point along the way there needs to be some determination made that this individual has to go further into the continuum of care.
We talked a little bit about the importance of cohesion or synergy. What are some results when that cohesion breaks down in a system?
Perhaps the best example that I can use is, so far I've described for you windows of time. We've talked about in a STEMI, we're talking 90 minutes. In a stroke, we're talking 3 hours. And that time frame actually has increased a little bit more. Talking trauma typically within an hour, okay? Now, let me just give you an example. So let's say that you miss that window of time, so that for whatever reason, that all of the responding agencies out there, and there's along the way there's a weakness within your system, and as a result of that, time is wasted, okay? And that time could be wasted at the scene, the time could be wasted at the critical access hospital, time could be wasted waiting for more rapid transportation, and all of a sudden that window of time expires, and that individual is no longer eligible, as an example, for thrombolytic therapy, which may have reversed that stroke entirely. That's typically what happens when you have one of the elements within a system breakdown.
Okay, so that clot busting treatment that would be delivered to the patients, they're outside that window and that treatment can no longer be delivered?
Right.
Okay. And I guess kind of along the lines of that, what is North Dakota doing well as far as system cohesion? Like, what are we doing right here in this state?
Well, there's a lot of right things that are being done within this state. We have a new focus on sudden cardiac arrest. We're doing that first of all, I will tell you from my perspective at the health department the things that we're doing. But let's recognize that we're just a small part of it, that there are many ambulance services out there, many hospitals that are out there, many dispatchers that are out there that are doing things right. A lot of them have done things like system development within the local or the regional level. Some of the things that I can speak probably to better with regards to what we're doing within the health department is right now we're working on what's called cardiac ready communities. Okay, so a cardiac ready community is something where we basically have the criteria for a community. It's usually something that the community has interest in. It's essentially focused on, again, such things as bystander CPR, recognition, availability of AEDs. There are some other preventative kinds of things in it. One of the things that is part of it is that we do, as an example, hypertension screening as part of the cardiac ready community. But there's certain, basically, designation criteria that they have to meet within the community. So a pilot project was done within a community in North Dakota called Powers Lake, North Dakota, small little community. And basically what happened was we found that they trained over half of the population in CPR, bystander CPR. They trained everybody within the school. I think, and I'm not exactly certain about this number, but it's a community of 400 people. I think they have 32 automatic external defibrillators in basically strategic places within their community. I know their hypertension initiative found about 15% of the people there that they tested were undiagnosed hypertension patients. So that helps with regards to the future as far as prevention is concerned and so forth. And then they've strategically located these AEDs. So in Powers Lake, if you have a sudden cardiac arrest, I think you could have the expectation that you're going to get bystander CPR, that there is an AED that's available within a relatively short period of time. And, basically that is part of a system for the cardiac care. And, that's now going to be replicated in many other communities in the state of North Dakota. I think we currently have 15 letters of intent for 15 other communities who right now are participating in building cardiac-ready communities.
Okay. So with this cardiac-ready community, it's basically seems like what we're trying to do or what's trying to be done is you attack kind of all of these preventative measures that you can put things in place before a cardiac event would happen to allow that event, to allow maybe the treatment of that event to go as smoothly as it possibly can to create the best possible outcome.
I would agree.
Yeah, that's really interesting.
It definitely puts it, it front ends it, a lot of the resource expenditure because if the investments into getting people educated in CPR and proper signs of determining this person's in a cardiac arrest, do you find that saves a lot more money compared to say someone having to go through the entire continuum of care? I mean, I guess might be a silly question,
like cost effect.
But in terms of cost effectiveness, do you find that it's a very cost effective solution engaging in a solution like a cardiac ready community?
Well, I think in a number of different ways it can be cost effective. It also may cost the health system some more if you have a greater percentage of survivability. So obviously, if you don't successfully resuscitate somebody, they're not going to utilize those healthcare resources. However, if you can have some of those, what I consider to be the preventative care kinds of situations, I think you can offset some of those healthcare costs that are basically, that you're going to have to face in the future. So I think if you can prevent that from happening, then I think it's a good thing. And I think it's an awareness within the community of cardiac health. So it isn't, the prevention isn't just a hypertension screening. It's walks that they have. It's, these different kinds of activities that just brings the awareness of cardiac care to the community. And all of a sudden you have a community pulling together to say, we need to have good cardiac health. We need to have good resuscitation within the community, but we need to have good cardiac health as well.
That's really cool. So you're kind of reprogramming kind of the way a community interacts with heart health.
Yes.
That's really cool.
Yeah.
So in a way, with this reprogramming, this restructuring, if the idea is that, if we want to teach more people about, what's a cardiac arrest, how to perform CPR, do you think that this is applicable, in the case of a cardiac ready community, is that more applicable for other issues as well? Do you think that in terms of, for the entire continuum of care, for just any sort of health issue in general, that having more community engagement in those type of topics, do you think other topics besides just any sort of emergency medical situation where it's a time critical event, do you think any other type of situation can benefit from this type of construction?
Well, my belief is system development, and I will only speak about healthcare. I'm not going to talk about manufacturing or any of those other kinds of things, although at least some of the quality improvement activities that I've been involved in the past are applicable to more than just healthcare.
Yeah.
But I think any kind of system development basically needs to include all of the elements. And, that's where I think we've kind of gone wrong in the past. And where we've gone wrong in the past is that what we've done is we've said, this is the most important part, and this is what we're going to build. And we ignore all of the other elements and all of the other parts. And when you bring all of that together, and that's the synergy that I'm talking about, that's when I think that the awareness really arrives. And that's when I think that you can really make a difference. So is it applicable to diabetes? I'm sure that it is. I don't deal with diabetes. I deal with strokes. I deal with cardiac arrest, STEMIs, trauma, respiratory emergencies, those kinds of things. That's the area that we focus in. So I can tell you that it's essential to have a system approach to emergency medical things. But I also am a believer that system development is necessarily in almost everything you do. I don't think that basically, and I recall an old saying is, who else is affected by this decision? And so if you're affected by the decision, you should be part of, of putting the system together.
So in this situation then, from rebuilding even, I guess, from transitioning to possibly a tiered system of response in North Dakota, do you find that there's a lot more feedback and input from people on the ground, I guess, more so, or just the community at large? And if so, if there is any feedback, how is that feedback getting to you?
Well, it's always a frustrating thing that we have in healthcare is feedback, okay? So let me just give you a great example, okay? So in my past career, one of the things that I did is I worked for a large integrated healthcare system, okay? And I had a number of different clinics that I was responsible for across North and South Dakota. And so I had one of my physicians in an outlying clinic tell me one day that he had a patient come in and he said, so how have you been since I saw you last, which was 6 months ago? He said, well, I've been fine except for that coronary bypass surgery that I had, which he had no idea that his patient had gone through coronary bypass. So the feedback loop oftentimes has not been closed. And one of the reasons why is because we've never worked together as a system. Once you start to work together as a system, you start to share information. There's also kind of, in healthcare, there's something called HIPAA, and it's the Health Privacy Act, and everybody hides behind HIPAA. I can't tell you anything about this patient because of HIPAA. Now, the thing about it is, if you've been involved in the care of that patient, I think it's important that you get feedback as to, whatever you've done with that patient, has it made a difference, either positive or negative, whatever the case may be. So I think, awareness throughout a community by being involved in a system, I think you get feedback, that goes through the continuum of care as much as appropriate, as opposed to no feedback when you're not involved in a system.
And going through this idea that we're putting patients through this continuum of care, but also do you see that you brought up a great point about communication between these different groups. Is communication then just a something that's going to improve as technology gets better? Has technology had an effect on that communication between these different agencies working together?
You hit on what I consider to be a real weakness within healthcare, and that's communication. Whether that is communication, between the different segments or elements, or whether that's just general communication in itself. Now, one of the things, and you talk about technology, so some of the things that are starting to happen across the United States with ambulances is telemedicine is basically being placed within ambulances itself, so that you not only basically have an individual who is performing their advanced life support techniques on that patient, but can be overseen, for instance, by the emergency department. I've already talked about, the 12 lead EKGs that are being transmitted. The new communication stuff with regards to electronic patient charting, as an example. Having access to that patient's chart while you're on your way to an ambulance call really is pretty significant. If you know already some of the history of that particular patient, some of the issues that they've had, may lend itself to helping you make an operational diagnosis. Understand EMS personnel do not make diagnosis, but you have to have some idea of what's going on so that you can treat that patient appropriately. All of that is based on communications. That is only going to improve in the future. There's a whole new thing that's out there now called FirstNet that is broadband specifically for emergency medical services. I think you're going to see a lot of communication and technology developed in that area in the next few years.
So what is the biggest misconception about how systems interact that you've come across in your career?
I think the biggest misconception is that healthcare itself is a system. And, it takes work to put a system together. It takes work for all of the elements to communicate with one another. I mean, when you talk about diversity, you might be talking about somebody who lives in a small town within the state of North Dakota that you have to reach with regards to what are the appropriate steps to take. How do you recognize something? Then what do you do about it? Then you basically get to a communication center. You may get some instructions. You basically then have a tiered response system, those types of things going all the way up to an ambulance service, to a critical access hospital, to a tertiary care facility. And the biggest, I think, misconception is that all of that works smoothly all of the time. And I don't think that it does. I think that it takes great effort to make systems work effectively.
And so a lot of these the issues that you talk about, I guess a lot of it could be behind the scenes, right? So stuff like if it's been a long day for an ambulance crew or something like that, or the more likelihood of fatigue on health providers, could result in mistakes possibly being made and things like that, or either just a slowed down response to something. Is there anything in particular that you find that in North Dakota even, is there anything in the system that you find that we kind of lag behind on?
The big problem that we have within the state of North Dakota, and it's shared by Montana and Wyoming and South Dakota, is that basically we have people very sparsely populated large geographic areas, okay? And everybody expects to have the same level of care. And in order to be able to provide that care, is a lot more difficult in some of those, remote geographic areas than it is within Bismarck, North Dakota.
Yeah.
And so, yes, there's frustrations with that, because what you'd like to do is you would like to have every citizen in the state of North Dakota have access to the same health care that every other citizen has access to. The reality is that just doesn't happen. I live in Bismarck, North Dakota. I have access to 2 cath labs here.
As
opposed to if I lived in my hometown of Bowbells, North Dakota, I would have to travel 68 miles to Minot to have access to a cath lab. So, that's an inherent issue that is very difficult to overcome. So, we don't have, if we had jetpacks on people where we just basically could just send them as quickly as possible.
Jetpacks on the hospital.
Well,
that's what it is. That's what it is. You just need your jetpack personnel to be trained in jetpack use, strap it onto that person having the cardiac arrest, and shoot them off.
Right.
I'm ready for the
Bismarck.
future.
Yes. Bring the future
have a
here.
magnet that draws them into the cardiac center. Yeah.
Start developing a tractor beam and just
Yes.
Yeah, exactly.
pulling them
Like
in.
the dental bus, it's
dental
perfect.
bus.
We're moving and grooving with this. If you could kind of sum everything up in one takeaway message for any of our viewers or anybody out there about systems of care, what would that message be?
I think the message would be essentially this. If in my worst hour of need, I had a system available that is going to give me the greatest chance for survival, that's where I want to be. But I think the ultimate success is greater with a systems approach than without.
Yeah. And kind of realizing that we are all a part of this system
Yep.
and improving its efficiency.
Right.
So that's a really good point.
Each one of us has a part to play, it seems.
We do.
Yeah.
We do.
That's awesome to hear. So now just for all of us, even at home, just get on out there, to work with your local communities to kind of get out and improve outcomes in your community. So even just looking at places like Powers Lake, for example, just even if you want to feel like organizing something for your local community, that's a pretty good idea then, huh?
It is a good idea. Yeah, I would agree.
Well, yeah. Well, again, if you have any questions, feel free to hit us up in the comments section or like us on Facebook and give us a response there. But thank you, Tom, for joining us
Yes,
today.
thank you very much.
Thank you, guys.
Yeah, and just being with us today. And thank you guys for joining us today as well. We had a wonderful time, and we will catch you guys on the interwebs in the future.
All right, and have a good day.